It's a pleasure to be here. So when they first asked me, I said, oh, just won't you come and chat to some students? I thought we'll sit around and we'll talk about some experiences we've had in healthcare and innovation. And it's amazing to see this packed room, distinguished students and professors. This is really about an opportunity to expose and inspire and change the way that we think. Right, and just suspend disbelief, suspend our perceptions of reality in the way things are. As part of this, I'm going to try and give you a bit of a personal journey, and it's certainly, as you've heard, somewhat unconventional, and still doesn't fit within any particular paradigm or system. And that's a daily struggle, right? But it's also important to realize that where we've started from and our real intentions of why many of us are in this room tonight is because we feel some personal duty, a responsibility, a passion, a sense of moral duty towards improving the lives of others, regardless of whether we're directly in the field of medicine or not. Let's see if this works. So there's some sense of there's a human right behind all of this. Before we run away thinking about new ideas and new technologies and sexy things, like why are we here to begin with, right? How is kind of healthcare a human right? And what does that actually mean? How do we realize those rights? So we've got fantastic declarations of how we can achieve the greatest standards of care of healthcare, declared by all our big international institutions and by our own constitution. But the realization of these ambitions is often where we fail. I quote, the goal of health as a human right is nothing less than the refashioning of our world into one where no one starves, drinks impure water, lives in fear of the powerful and violent, or dies ill and unattended. It's quite a vision for health. Right? It also means that those of you in the room who are not in so-called medicine have a critical role to play. And that's why we really encourage this kind of multidisciplinary approach. The Bertha Centre being at the business school is exactly an example, and the field of social innovation as itself, as an emerging academic field, is one by nature interdisciplinary. As Walter explained, we have kind of obviously work in health innovation, but we've got a set of body of work in innovations in education. We're part of a global network looking at how the education system is changing in curriculum, in delivery of schools, in technology, in financing education. And if any of you are kind of passionate about healthcare, you're probably also interested and passionate about education in our country, because it's the other key piece of our future. And thinking about ways that we could reimagine our education system are something that we are also at the centre passionate about. So are we succeeding in achieving and attaining these high standards of health and ideals? Part of my journey, I started as a medical student here, as you heard. I went to Namibia for my internship. At the time, Namibia didn't have its own medical school, and 20 doctors from South Africa went to Namibia to run the tertiary hospital of the country in Windhoek. It's the equivalent of Groote Schuur. And my medical officer was the mayor of Windhoek, so you can imagine how often he was around. There were 3 pediatricians at the time in Namibia, all in the private sector, and they came and did around once or twice a week. So you have 20 young doctors totally wet behind the ears, thinking they're going to save the world, running a referral hospital and no one to send it to, and realizing the realities of healthcare and how little and how impotent we were. So I, as part of that journey, got really passionate about newborn care as a really important component of infant mortality. And in my master's in public health, started doing some research. And if any of you know the World Mapper, you probably would have seen this. This is maps that are produced by weighting data by country, and you can choose different kinds of statistics. But essentially, so this maps out the burden of neonatal mortality. So that's India, that's Nigeria, and this is obviously sub-Saharan Africa. So the size of the country reflects the burden of disease and the burden of mortality in this case. So to answer the question, are we succeeding in attaining these ideals and some kind of utopia? The reality is that's where the healthcare workers are. All right? So you want to see that again? So it's basically exactly opposite. So we're at a business school, we teach economics, demand and supply, right? The market will solve all these questions of demand and supply, right? Isn't that what free markets are about? Isn't that what the world imbalance is about? And somehow this, the demand for services and the supply of what we need, which includes not only healthcare workers, nurses and doctors, but medical equipment and technicians, is that. And so kind of why do I show this? It's a big picture to say we have grand ambitions of the standards of health, the outcomes we want to achieve, and our resources are relatively limited. And yet in South Africa we spend significant amounts of our GDP on healthcare, and we spend more than any other country in Africa per capita on healthcare. So it's not only about the resources, and particularly for South Africa, it's not only about the resources, it's about how we organize ourselves, right? It's how we organize our resources, our healthcare. And there are efforts in the country clearly working on understanding how we improve it. And clearly many of you know about national health insurance, and that's not what we're going to necessarily cover today. I mean, that's a large innovation in itself. So what we, I guess, have been trying to do as part of this initiative has been trying to understand and define innovations in healthcare beyond just technology. And I think we're trying to understand, what does healthcare innovation mean for us? What are we trying to achieve by it? As opposed to, what are we interested in developing, some new tool, some new technology, an app on your phone that measures your blood pressure? How is that changing health outcomes? So what we started with, and I guess the purpose of the summit and the purpose of this and inspiring people, is to understand how can we define what healthcare innovation is about beyond technology. It's about, for us, it was really about delivery. So often we have the tools, and if you look at what South Africa's investment in healthcare innovation is, it's in drugs, diagnostics, devices, and vaccines, which are important investments to make. But for many diseases, we actually have a lot of those tools already. It's about implementing them, getting them to the right people at the right time, and actually using them effectively. So we were really interested in technology, but also in how these things get implemented and how they reach the places they're supposed to reach the outcomes we're all interested in. So we're particularly interested, and I've been particularly interested in my career, in innovations that bridge all of these market failures and government failures. So they range from things like policies, public programs, public-private partnerships, non-profit approaches, social enterprises. Clearly we are a center for social innovation. We're interested in social enterprises, and also corporate initiatives that might lead to improving health outcomes through bridging some of these failures that we see. I'll give you some quick theoretical definitions, but I won't stay much time on it, so people ask kind of what social innovation is about. Often it's interested in effective, sustainable solutions for which the value that accrues to society. But we're really interested in things that go beyond just developing an initiative, a product or process, but actually start to address the underlying routines and authority flows and resource flows. So basically the causes of what underlie some of the challenges that we see. So innovations that address the problem just by fixing the problem is the first step. Innovations that start to perhaps address some of the underlying causes are things that we're particularly interested in and are particularly difficult. I just want to show a quick thing, because the word social entrepreneurship is used quite often and we're a center that focuses on it, but I just wanted to put it in some context, that we're interested in a world of innovations that happen in a range of different sectors. And what we see as social entrepreneurship happens inside that world. So the kind of more entrepreneurial approaches, the business model approaches. But we're also interested in others that take place outside that, and I'll show that. And then social enterprise, just for a quick definitional attempt here, is to show that those are really kind of business approaches that look at both social and financial returns. So it's a smaller world, but a world that's particularly fascinating, and a company like Aravind that was shown in the video is basically a social enterprise. It's a business that really has a social purpose, but runs like a business. So social innovations are sometimes a little bit surreptitious. So this is a kindergarten. So 100 years ago, the person who brought the concept of a kindergarten to society was considered, an outcast, just like Semmelweis, who brought the concept of washing hands into a healthcare system, was considered an outcast. So often these things start as, the initial reaction to anything new is clearly a resistance. And why should kids be educated before they go to school? Right? I mean, they're going to school to be educated. They don't need education before they go to school. And clearly now we know, early childhood development is one of the kind of most important factors for success in a school system and things that happen in that critical period. So some social innovations which kind of take for granted that they now exist in our world, but they were at some point implemented into a system. So I'd like to think about, going forward, some of the things that we think of as totally crazy today might in 100 years just be the way that we operate. And that's the reason I show you that. And also the source of where these things have come from is also extremely interesting. I mean, I put up there 100 years ago, just to give you some context, there were only 2 countries in the world that had given women the vote. Does anyone know what those 2 countries were? Yeah, New Zealand was one of them. And Australia was the other one. The last country, not the last country, but the last of, there's still some that don't give women the vote, but one of the most recent, and Switzerland, very good. Appenzell in 1981. So in most of our lifetimes, women didn't have the vote in Switzerland. Right, radical ideas, crazy. So part of the point here is that innovations come from a range of different sources, and not only from the sector that one thinks they end up in. I'll give you 2 quick examples of that. One is mobile phones, right? Clearly, corporate innovation, commercial motivations for rolling out mobile phones across the developing world, massive industry, and yet significant social impact just in terms of access to communication and access to information. On the other, so that was totally corporate-funded ventures, large industry, but has had and continuing to be explored, and in healthcare, as many of you know, to explore what are the potential of these tools. On the other end of the spectrum, there was a technology developed called One Laptop Per Child. Have any of you heard of this project? Started 25 years ago in MIT Media Lab. And as a technology project and as a hardware project, it was funded by donors, thinking, okay, how do we develop products to bridge the digital divide? Right? How do we think about people who live in rural areas who don't have access to electricity? How do they kind of wind up their laptops? How do they see it outside in the sun so the screen's not reflecting? How do we keep the energy use low? Let's kind of innovate the screen, because the screen's the part that uses the most energy of a laptop. Problem was, as a technology project and a hardware project, it was a total failure. Right? I mean, tablets have totally blown the One Laptop Per Child out of the water. Their vision was to get to a $100 laptop, right? You can buy a $35 Akash tablet now. So as a hardware project, as a software, they learned some interesting things about education. But what came out of that totally donor-funded venture came the e-ink technology for the screens, which became the Kindle and the e-readers. Right? So big commercial industry coming out of a humanitarian project. And then the reason I give those 2 examples to show that to presuppose where ideas come from, right, and what industries they belong in and how they might be funded and what their sustainability is a false dichotomy to think we do things in the social sector and the public sector and we do things in the corporate sector. Right? And the purpose of that is to kind of get away from that dichotomy of thinking. Great. So we've developed some approaches, and I'm just going to run through this very quickly because otherwise I'm going to be too long, about how we start to address challenges. And the only point I want to make here is coming back to how we see social innovation. We want to get away from the negative mindset of fixing problems and filling gaps. And that clearly we need to do because there are huge gaps. But if we can also start to think about what are the assets we have, what are the possibilities that are there, how do we co-create rather than just deliver? How do we evolve rather than just develop? Are we on a development trajectory to be another developed economy? Do we want to follow the healthcare system of the United States? It's not working for them. It's too expensive. So should we not evolve? Can we not create our own path in some way? And let's not think of things in black and white. There are continuums at play. So thinking of these innovations, clearly there are improvements we're doing all the time. And so this word innovation, in some sense, starts to lose its meaning as people use it more and more. But if we can think about it in incremental senses and improvements, and that, I think, is a common process, the radical disruptive ones around how we totally reimagine our healthcare, like NHI, are extremely difficult and rare, but very important to start thinking about how we do that. I'll give you a quick taste of some of the world that we operate in, and we're interested in how the world between these dichotomies of non-profit and for-profit and public sector are changing. This, in the organizational spectrum, for-profits have come under a lot of pressure to be more responsible, and non-profits under a lot of pressure to be more sustainable. Right? And in that world has emerged a whole range of different business models that are interested in both sustainability but also how they create social impact. And that's a lot of the work at the Bertha Centre that I'm not going to spend too much time on. Similarly, the way that money is flowing in the world is also changing. And donors are starting to think more in terms of performance and more in terms of long-term sustainability and less in terms of dependence. And again, traditional investors are starting to think there might be opportunities for their capital to take place in the social sector. And also, there are a lot of pressure to be more responsible with the way that we invest capital in the world. And I'm going to give you one example of that as we go through things. And then there's a process, and all I want to start here is that we've been promoting to start this process of looking at innovation by understanding needs. There's no point in starting with the technology and then saying, where can we apply it? Right, let's really start with the needs. And we know the needs in South Africa are significant. So you can pick something that you've written on your piece of paper, and I'm going to pause for a minute and ask you to speak to your neighbor. And I want you to, in 30 seconds, very quickly, tell them what that problem was. Don't tell them what your ideas of solutions are. And give them 30 seconds to think about it and to come up with one idea. So introduce yourself, tell them the problem you wrote down, and ask them for one solution. You've just shared an idea, hopefully, if you could manage to think of one that quickly. But it might be the kernel of something. I want you to now, I'm going to run you through the approach that we developed. And in the Health Innovators Review, we were looking for people who took this approach. Particularly, we were biased in this. And we were looking for those that were needs-based and empathy-driven. So are you actually thinking about the person whose need it is that you're trying to address? Right, so start there. Ask yourself that. Is it for them? Or was it for you? Right? Have you thought about the process? So take this idea. Now you're going to have to take this idea and actually think about how you develop this idea into a potential reality. What's the process you might undertake? Could you include those people in that process? Think about that. Could you try and think about as radically and provocatively as possible without the first thing in your head going or the person across you saying, no, that you can't do that? Can you think about how it might change the routine and attitude of people, not just the process? You won't be able to achieve this. Might it be totally transformative? Not in the 30 seconds, but it's about the process. So go back now, that same idea, think about, is it needs-based? Is it driven by empathy? Is it for the people you're actually thinking about who are in the system? It may be a system problem you talk about, or you even talk about the person or the people in that system. And could you think about how you might co-create the idea with other people, either outside of the system or in the system? So you can go back to that same conversation, and then I'll stop you in Shortwood. I'll leave the list up. Yeah, I mean, it's a guide, not a toolbox. Hopefully by now, that idea is a little bit grown, changed maybe completely, but the challenge was to think about how it could be more inclusive, right? Because often we get wrapped up in the idea for the sake of the idea. Oh, that's a good way to fix it, right? So that was our challenge, and that's kind of part of what we're trying to see is what's the definition for health innovation for us in South Africa and on this continent. I'm just going to run through all of that. And that's what we did in the Health Innovators Review. We looked for South African innovations that were inclusive, so they somehow reached a greater number of people, that were affordable, so were kind of either cheaper overall, more affordable, or per unit or per patient or per outcome, and were effective. They actually had shown some clinical outcomes. Because we always get, often the marketing and media around kind of new ideas is significant, but often the evidence around whether they really work is sometimes lacking. And for those of you who, I presume there are copies going to be around, or if they're otherwise they're on the website, downstairs, Health Innovators Review. I'm going to just show 3 quickly, but I actually would rather show you a couple of international examples, because I think the South African examples many of you may know, or you can certainly read up in more detail in the review. But basically we had over 100 nominations from across the country in a range of different areas and disciplines. Those that were really what we call transforming the system from the inside out. And so we were particularly interested in innovations that came from the front lines, that came from people who understood the needs and responded in ways that addressed them in inclusive ways, affordable ways, and effective ways, that were not necessarily coming from the top down. I think there's also a lot of kind of research and a lot of policies that come from the top down. So we're really interested in how can the system be improved from the bottom up, and what we call from the inside out. Hence the name of our newspaper that's lying around as well. So Breathe Easy, for some of you may know Jane Booth. It's a long program that actually provides the system and the care for children with tracheostomies at home in places that don't have electricity, that are townships. And when international kind of guests and visitors come and see this, I think it's something that's been impossible that's been created. But essentially it was a service that was created around a need. I'm not going to go into too much detail on each of these. Again, from the front lines, an easy spreadsheet-based prescription system that really created legible scripts. I mean, do you really need to be writing out long repeat prescriptions? Yeah, typically, I know what most medical students' handwriting looks like. And then, finally, as many of you know, there are solutions enabled by technology. And those of you who've kind of seen or learnt about Hello Doctor starts to overcome some of the issues around access to health information. So who drives all these things? They're driven by individuals, and often we see the kind of hero model of the innovator and the great inventor or the great entrepreneur. But they're also driven by movements and by organizations and institutions. And so now I'm going to show a couple of examples that have fascinated me in my career of innovations that really bridge market failure. So now I'm going to stop talking about theory and really give you some nuts and bolts. Sorry, there we go. So many of you may know, and this is a South African innovation, and one that again is not a high technology solution, but is really around how we organize care and how we really take that concept of task shifting that many of you may know about, may have heard about, which is trying to understand how do all of the tasks that healthcare workers undertake, how can these be shifted and shared with other people in the system. In this case, actually patients in the system, mothers who had been through a process of being diagnosed with HIV in their antenatal period, gone through the process of counseling, taking treatment, going through birth and making a feeding choice, and all of that time requires a huge amount of time for doctors or nurses to counsel the mothers. And in a heavily overburdened system, this was clearly a model that started to work well because it was simple. And basically they had mothers who'd been through this to be trained and then mentor and counsel other mothers going through it for the first time. And why it's interesting, because it was a simple solution, was able to scale. And the point that for me that it got interesting and harder to start to bridge some of the challenges is when it became adopted into policy. So in Kenya, they've actually adopted this mentor-mother policy. It started in an NGO, which started actually in the public healthcare system in South Africa, and is now adopted, and there's a plan to roll it out into 600 sites in Kenya. So it's fascinating. One of my kind of interests along this journey and something that stimulated me was skin-to-skin care. Again, this is not a technological solution. I kind of see it's not a high-tech solution, it's not a low-tech solution, it's a no-tech solution, right? There's no technology here except the human body. And as many of you may know, the evidence on this, the Cochrane Systematic Review shows that it reduces prematurity, deaths from prematurity by 51% in developing countries. But it's certainly used now and that in its sense is, it's a medical innovation, but it's also a social innovation because it requires a set of behaviors that needed to change around implementing this to actually save lives. An interesting financial instrument that we are starting to look at is something called a social impact bond. We're doing some research for National Treasury and the Office of the Presidency on financial instruments that can actually lead to social outcomes. And a good example of this is a social impact bond in Mozambique around malaria. And this is interesting because essentially it aligns public, private and civil society interests for the first time around social outcomes. As many of you know, governments, their health budgets are consumed by running facilities and the resources and the human resources are basically paying salaries and managing the hospitals. Often it's difficult for them to invest in preventive measures, right? That's often expensive, but they can't take the money away from running the hospitals and paying the doctors and nurses and staff to spend in prevention, but if they did, they might actually be able to reduce the workload they have. So they're in a chicken and egg situation. So the instrument of social impact bonds is starting to be interesting in preventive measures, not only in healthcare, but in prisoner reform and in early childhood development, in a range of different, in kind of youth empowerment. But take the example in Mozambique. So we actually know what the interventions need to be to prevent malaria. We know how to prevent malaria. You educate people, you provide them with long-life insecticide-treated bed nets, early diagnosis, you protect the pregnant women particularly and the children under 5. So we actually know how to prevent malaria. Yes, we know how to treat it, but there's a very high incidence and burden of malaria death, particularly in children. So how do we find the capital to invest in those interventions that we know? In this case, we actually go to investors who might be potentially interested, business who are losing productivity because their workers are suffering from malaria frequently, many days off during the year. There might be other investors who are interested in both a social income but also in a financial product. Governments, in this case the government of Mozambique, might be prepared to pay for an outcome that says we're actually reducing the incidence of malaria in a particular district. So in this case, they're saying, well, if we are able to do that, if we know the set of interventions, we pay service providers to do that, the government has not paid anything yet, only until those outcomes are achieved. Right? And they know if those outcomes are achieved, we've reduced the burden on our healthcare system. There are fewer people with malaria in our hospitals. And we've also, so there's a direct cost saving, and there's an indirect cost saving and a benefit to society because we have fewer people that are ill and are productive in the economy. So they are prepared to actually pay for that outcome. So we actually know roughly what that burden of disease costs us. So we'll pay whatever, $40 per person who doesn't get malaria and $100 per person for someone who doesn't die from malaria, right? And in return, if those outcomes are achieved, they provide that payment back to the investors. The investors potentially get a return on their investment. And the way these deals have been structured around the world, there are more than 20 social impact bonds now. There's a range of return on investment that range from fairly marginal returns, 3% right up to 15% on a sliding scale. So it's a fairly complex financial instrument, but the important thing about it, for the first time, that the investors who invest in commercial capital sometimes soft capital, are interested in the social outcome, because that's how they're going to get their money back. So they're really interested that this agency delivers this to what they've all agreed on. The public sector's aligned to it because they're interested in reducing the incidence. So a very, very interesting instrument. And it's interesting because it starts to link for the first time financial returns and social performance. So clearly a public-private partnership mechanism, and there are lots of different models of PPPs, and you can read journal articles around all the different PPPs in health, from product development partnerships to kind of delivery partnerships. You can read about them, and this is a one around finance, which I just thought I'd give an interesting. A non-profit approach is one that many of you may know or at least recognize as a TV program called Soul City. which was really started around trying to understand behavior change in HIV in South Africa through mass media communication. It's one of the most powerful tools, and it's one of the ways that many people kind of get information today. So instead of creating a 10 o'clock in the morning show that is educational, they thought, well, why don't we do kind of prime time soap drama? That's kind of what people understand, and that's what people watch. But if we do the focus groups and the research around what the key messages should be and the kinds of messages that we think change behaviors, and research what kinds of behaviors might change after this, and put the right messages in, and if someone's calling a call center, there's a real number flashed on the screen around what that call center is, and it really is the number of a call center. So it's linked to aspects in reality, and inform patients about their rights, and inform patients about kind of how they might approach a healthcare system or think about their own disease and their own behaviors. It was a really interesting approach, but it's a non-profit that suddenly was creating, prime time television series and being able to sell it because of its viewership. Translated into several languages, now in 7 countries in sub-Saharan Africa. Non-profit with a revenue of over 120 million rand a year. So it's kind of strange. What kind of non-profit is this? It was a really interesting approach, and their whole mission was around kind of changing behavior, a really ambitious mission. Interestingly, the group that did this are now running a similar initiative called there's a TV series called Hopeful that many of you may have seen. If any of you watch kind of primetime soapies in South Africa, Hopeful is a drama that's trying to change the attitudes that we have in South Africa, and the respect that we have for each other, and the understanding of our own diversity. I mean, that's fairly ambitious as a goal, and to do it through a production TV series that's run by a non-profit, also linked to church-based institutions to allow people to take action around those values of respect and dignity, and around the characters, because we live in this kind of world of understanding movies and people and characters and stories. So fascinating. It's the same people who did Soul City. Another non-profit company that was a world first, and is a non-profit pharmaceutical company. You can think, what's that, and how does it survive and sustain itself? It does. It's actually spun out into another one. One World Health was created to really address all the so-called neglected and tropical diseases. And if you know anything about how the pharmaceutical industry works and how patents work, is that there are many drug molecular designs that are sitting on shelves in all those companies, because there's no market for them to really be developed further and have the investment required to actually do the drug development, the clinical trials, to actually understand whether these might work against certain diseases. Leishmaniasis is one of the examples. And what One World Health went around the world doing is went to universities and went to pharmaceutical companies and said, give us all that stuff that's on your shelf that's you're not going to use. And it worked. And they basically then started running through all of these and finding the investments to actually take those through to product development, clinical trials, and registration. But again, just kind of what LD said and the team said in the video, why do we just accept the way the world works? Why do we just accept that we rely on for-profit pharmaceutical companies to take things to market? There might be different approaches. And here are small indications. And all of these things I'm showing you are really experiments. They're experiments and indications of the way that our world might work differently, and that we might not be reliant on and accept just the status quo of how things operate. You were shown Aravind Eye Hospital. I've had the pleasure of going there, and also to the Narayana Institute that some of you may know about. The other way they do this eye surgery is in radial spikes. So they have the surgeon in the middle, and they have several patients around them. And each one will be prepared by a nurse, and the surgeon just does the key part of the surgery that's required of him. So they're basically trying to specialize down to the scope and the key skill that's required of that surgeon. And everything else is done by a number of other people, either nurses and registered, trained professional nurses, but also a whole range of people who don't necessarily have so-called professional regulated training, but have been trained to do a number of other tasks. And a good example of this, we were just chatting with Rick de Decker before this, is the Narayana Institute in Bangalore. Their pediatric ICU, just the pediatric ICU, is 80 beds. It is massive. How big is Red Cross ICU? 23 in total. And how many of those are cardiac?
Depends on the day.
At
0 to 3.
from 0 to 3. Okay. So just the scale of what happens here is phenomenal. So their cardiac surgeons, I think, are doing, I don't know how many a day, but many. And essentially what they've got is a number of things happening here. There's a business model underlying this, which is cross-subsidized, serving kind of richer population. They've got about 30% of all patients here are free. And they've got a kind of a middle road of a whole bunch of people on micro health insurance that covers about 2 million people living in rural India. So a phenomenal, interesting model. So there's a kind of a business model innovation around it. There's a whole bunch of process innovations around it. And there's kind of task innovation. So I was also explaining that they have people who've just graduated from school trained in echocardiography. So they don't need to be a doctor, they don't need to be a cardiologist to do an echo. But I mean, you could probably train anybody to do an echo if they have reasonable eyesight, unlike me, and are able to concentrate. And all they do is echoes, and they do 20 echoes a day. And the cardiac surgeons and the cardiologists now say, actually, I go to them to ask questions because they're the experts, because that's all they do. They specialize. So fascinating way of managing a system. And then companies have started to kind of innovate as well. So I've kind of been going through all these different sources of innovation and how they start to bridge these failures in the system. So many of you may know that South African medical schemes and the health insurance industry is heavily regulated in South Africa. We only have 14.9%, I think, of people in South Africa on private medical aid schemes. And the limit to developing lower cost health insurance in South Africa has been heavily regulated by something called the medical prescribed minimum benefits, right, which really reduces the ability of companies to provide affordable products because they need to cover this whole range of conditions. So in India, there are 60 different micro health insurance schemes. So we don't have one really. And domestic care and workers' care is the first one that's emerging, and it's basically using a loophole. It's not using the Medical Schemes Act, it's using the Occupational Health Act. And what it provides, for the first time, any of you who are on medical aid probably have the hospital plan, and maybe, you know, if you can afford it, you really require, you have the comprehensive plan, which gives you primary care as well as hospital care. But actually, most medical schemes provide hospital care cover. And if you think about it, the stuff we need to be covered for is actually primary care, and if we sorted everything else in primary care, we'd be kind of far better off and probably far less reliant on our medical schemes covering hospital care. So there are all sorts of issues in the private sector's medical health schemes that I'm not going to go into, but what this does for the first time is provide a 200 Rand a month health insurance product, which gives comprehensive, unlimited GP cover. Do you want me to say that again? Comprehensive, unlimited GP. You can go to the GP as many times as you like and they'll pay for it. What happens is the first month everyone goes 4 or 5 times and they realize it's a waste of their own time and it kind of works out. Provides chronic care benefits, provides ARV, HIV benefits, provides radiology, lab things for 200 Rand a month. But it's only primary care. So if you need to go to hospital, you either go to a public sector hospital or you have to pay for it yourself. And what they've done is they've gone to the large employers, because it falls only under the Occupational Health Act. So the loophole and the trick is you have to be an employee. You have to be a registered employee of some company or some agency. And what they've gone to the large companies in South Africa and say, either provide this for your employees or cover 100 Rand, and they can cover 100 Rand a month. So they've gone to ShopRite, 60,000 employees, who are not on medical insurance. For the first time might have. And so these are some of the things that might start to take the load off the public healthcare system. Another innovation is Unjani Clinic. Some of you may have seen, this is a corporate initiative trying to create low-cost healthcare clinics in containers in areas where government clinics are not present. And so they're working in combination with government to try and make this a complementary service. Nurse-run, nurse-owned, so it creates a job potentially for a nurse. So it's a private sector initiative, but for the first time, it's trying to create a low-cost private healthcare solution. Still has some way to go, but an interesting initiative. And then I think LifeSpring was right at the beginning, but that got mixed up a bit, but I can come back to it. And this is actually a business venture in India providing low-cost maternal care. Again, they've specialized only providing maternity maternity care. And what they focused on was kind of relatively low risk women who probably didn't need any kind of complicated maternity cover, and then they started realizing so initially it was just clinics, and now they're adding on theatres to be able to provide more complex coverage. And again, low cost. So I've given you some private examples, some non-profit examples, some public-private partnership, and some policy examples of innovations. And I guess the point is to say these things aren't the holy grail, right? You would have realized that yourself. Each one you saw, you probably said, oh, but there is a fundamental problem with that, or that's really not going to transform the system. I agree with you. All right. The point is they're starting to give us ideas and experiments and break our mental models of how we accept what's around us. So they're not shortcuts either, right? We still have to do the hard work of building the NHI or of building kind of public healthcare systems. But they might give us ideas and examples and technologies and processes to help build what we do. And that's why particularly we're interested in the things that happen in that private sector or in that social enterprise sector, because there are origins of ideas of people not constrained by the system they're in. We haven't talked about unintended outcomes, and that's a whole other lecture on itself. But when creating innovations, one also needs to understand that sometimes you're doing something new. That means you're shifting a dynamic, complex system, right? And something else might shift on somewhere else that you weren't aware of. And finally, we need to support the opportunity to take on new ideas. And we particularly support them and listen to where they're coming from the bottom up, and not only from the top down. And looking at innovation, again, as a process, not necessarily an outcome in itself, and as a learning opportunity. And thinking about, particularly in the health space, how we create opportunities for taking risks, because innovation is about risk and failure, right, as well. So how do we create safe spaces for that, spaces where we're accountable, spaces where we're accountable for people's lives, to be able to do that responsibly, yet without kind of fear overcoming everything we do. And that we kind of need to embrace failure, right, as a step in that journey. And I think that's all I wanted to say for today. Thank you so much for your attention.